Good afternoon, everyone. It's a privilege to be here. The words cannot, my thoughts cannot begin to explain how humbled I am to be here and following such a distinguished panel. I'd like to begin my presentation by thanking Elder Emilia for her wonderful words of welcome. And I will take a little sidebar to make a comment about this province. I am of this province. My family landed in this province in 1658 in the Huron-Wendat region, which is a First Nation who has been colonized by the French, as many First Nation and Indigenous people in this province have, and who find themselves often excluded from these forums because for pragmatic reason we adopt English as the language of communication. So Indigenous, Francophone Indigenous communities find themselves often dealing with multiple level of exclusion and vulnerabilities as a result of this. And this is something that I became aware of some time ago. For pragmatic reason, my presentation will be in English, although I have included slides in French that can be shared if that can be of any utility to those communities. So the bumpy ride to equity, I am very happy with that some of the themes that I will be touching on have already been alluded to this morning, and so that I have some stepping stone that I can follow to help you connect the dot. The first slide, the first stepping stone is the last slides that Jeff had in terms of the boxes of equity, how to shift the box to achieve better equity. My program of research is to open the Pandora's box of policies and legislation in issues of jurisdiction and look at the underbelly of the beast, if you want, so that we can start understanding the complexity of addressing health inequities. And so this is what I'm going to be speaking of this afternoon. And I'm going to be showing you a lot of material because I'd like for you to get a glimpse of the underbelly of the beast. So I'm going to start with maps. And I assume that we're all familiar with this map. If you're not, please raise your hand. Nobody will dare to. Okay, I was looking for a map of Canada with all the regional health authorities, les régies régionales de santé, and I could not find one. But there are regional health authorities in BC, Saskatchewan, Manitoba, Ontario, Quebec, PEI, in Newfoundland and Labrador, and the Northwest Territory. So this map is not only fragmented across 10 provinces and 3 territories, there's also another map on top of it with regional health authority that make decision at the regional level. Okay, you're with me so far. Let's add another map. This is the 14 healthcare system. We talk about 13, there are 14 in fact. And this is the Indigenous healthcare system. And it's not a healthcare system, it's multiple systems. This is a map of land claim agreements across Canada. Those are territorial agreements. They're about land and resources. And some of them include jurisdiction over health. The James Bay North and Quebec Agreement does. The Seychelles does, the NISCA final agreement does. None of the agreements in the territories do, but one of the agreements that I helped negotiate, which is the Sioux Valley First Nation Agreement, which is a single community agreement, also include jurisdiction over health. So that's one layer. Let's add another one because I like complexity. Now, this is my ugly slide. There will be no other ugly slide, I promise. Don't go blind trying to read it. The blue communities are those where communities manage their own health services today. Those are transfer agreements signed with the federal government. These are First Nation communities, and they have jurisdiction over their own community-based health services. The pink one is kind of a self-determination light model where there's more sort of a blend of federal and First Nation jurisdiction. And the green one are where the federal government still provides services and has jurisdiction. There's a lot less green than blue and pink. So this is the healthcare system in Canada as it exists today. It's a quagmire of jurisdiction and complexities. And it's not necessarily problematic, but we need to be aware of that this is part of the landscape. So when we're talking about jurisdiction, when we're talking about equity, this is the baseline, this is where we are. Okay, you with me? Okay, it's going to get more complicated, but so out of respect for all of us who may be aging, apparently I am too, I've mentioned my key point, and then I'm going to walk you through how I got to those key points. The first one is jurisdictional fragmentation and confusion remains a huge barrier to equity. I'm glad that governments are recognizing this, and there's a commitment. I will show you how addressing that commitment is going to be complicated in a minute. The current policy framework remains a patchwork, and a patchwork is not those fancy patchwork. They're the patchwork that I had when I was a kid, where my toes would fall through holes, and then there would be a patch on that hole, and then there would be another hole opening next to it. This is what the patchwork looks like. International perspective on Indigenous control, it still is about, we're talking about community control. I showed you self-government agreement. I showed you community control, communities that manage their own health services. The question that I had when I started getting involved in Indigenous health research back in 1989 and was reading John O'Neill, of course, because you were the main publisher in this field. I'm still reading you. How much control is control? And control over what were my question in 1989. And I still don't have a clear answer to that, so I may be just a slow learner. But I think those are very complex issues to disentangle. And then I'll touch on the way forward. So that's my presentation. Now we're going into the nitty-gritty of how we get to those points. Jurisdiction. The metaphor of the spaghetti bowl, I don't have very poetic metaphors. I just go back to the familiar. This is not a spaghetti bowl that feeds everybody. This is a spaghetti bowl of jurisdiction and administration. So it's a big bowl that nobody can really feed off because it's all administratively constrained. This slide is complex, and it shows, and I'm going to have to get a little closer because I'm short. It shows jurisdiction for First Nation who live on reserve are not the same as those of First Nation who live off reserve. I'm increasingly becoming aware that Inuit that cross jurisdiction from the territories to the province encounter all kinds of jurisdictional barriers and confusion as to who's responsible for what, and that creates barrier to accessing services. Those who live in the territories also have limited access to equitable access to services because the territories are a site where accessing complex care is limited. And now we have a brand new category or brand new jurisdictional complexity, which is Métis and those who are not recognized under the Indian Act as Indians, so those who are non-status. And because of a court case in January of 2016, those are now recognized as Indian under the Indian Act. And I have no idea what that's going to mean in terms of who's responsible for health services and how the federal government looks after this population. Historically, the federal government has refused to be involved. Now, if you look at all those arrows, you may feel that there's complexity as to who's responsible for what. This is a gross undersimplification. For every arrows, there are multiple arrows going from funder to the service providers and to the communities themselves. Fragmentation across programs is humongous across Canada, and Linda Smith touched on that. It's the same in New Zealand. It's programmatitis. But in Canada, we also have pilotitis in the sense that many of our programs are actually not programs, they're pilot projects, and they're funded as such in communities. And at the end of the pilot, nobody systematized, even if it was very successful, it does not get picked up into program, and we start all over again. So us in the research communities are actually service providers in communities, are opening pathway to service provision in communities, in grossly underserved communities, through research dollars, which is an aberration. And there's no sustainability in that. We need to close the gap there, but this is a complex issue. The sphere of Indigenous control so far is there. We felt very comfortable in Canada transferring control over community-based services, primary health care. It echoes Alma Ata, the declaration of the WHO in 1978 that community should be involved in primary health care planning and delivery. We've not transferred any control at any other level whatsoever. There are some bits and pieces in there. There's consultation. The Assembly of First Nations is involved in consultation over federal policies. There's also the Inuit Tapari Kanatami will be involved. The Métis National Councils may be involved in some consultations, but it's sporadic, it's not systematic, and definitely is not a systems-wise approach. So that's the sphere of control so far. The current policies, I love my bridge there. This is the jurisdictional bridge across, so the bridge across jurisdiction. And it's not really an exaggeration. I've spent years doing studies of First Nation who relocate for medical reason and their experience of accessing care. And that bridge can look like that from their own standpoint. However, I have to say that the bridge is far more dire if you're on chemo or on dialysis, or if you have in tow little ones as well, right? So crossing jurisdiction is very treacherous. It is dangerous. It is sometimes arbitrary. Decision makers at the front end of providing services, so whether they're federal or provincials, also have their budget in mind, their own idea of who should be paying for what services, and their own idea of their own mandate. And none of that is clearly articulated. Only in BC and Ontario recognize, and this is BC before the First Nation Health Authority, although I'm not sure that the legislation actually changed, that Indigenous people have to have a say in regional health authorities' decision-making. That's what the legislation say. Everywhere else, regional health authorities don't have to consider Indigenous issues, Indigenous communities and their realities in decision-making. So it's two systems moving at different speed. Racism on accessible substandard care continues to be reported. The federal policy framework, it's the 1979 Indian Health Policy, it's a page and a half. And frankly, it's a goodwill sort of statement, but it's not a policy. It cannot be evaluated, and there's no accountability framework to go along with it. At the provincial level, we have policies that contain Indigenous-specific provision, but these policies are sparse. They look at tobacco for ceremonial purposes. They look at traditional midwifery, and these are in some jurisdictions, not in others. But nobody has really come out and say, as federal government, we are in charge of this, and as provincial government, we are in charge of that. And where there's jurisdictional gap, we have a mechanism to reconcile that. That does not exist. And that's part of the problem. That's why we end up with those bridges that are often built as a result of providers' goodwill and nothing else. So access to essential services in this country for Indigenous people is still a matter of goodwills of providers very often. And if that's good enough for you, that's definitely not good enough for me. I think there's an issue of human rights, and we've not addressed that issue. I'm hopeful that this government may actually do that. Yeah, I'm getting it to overtime. So last two slides, I promise. What's happening internationally? Well, in Canada, we focus on issues of governance over separate community-based services, the same in the US. Latin America and Australia, I don't think are necessarily model for us because they're still trying to accomplish recognitions of Indigenous rights, and they're just filling gaps in services, but it's really not a model that can bring equity. Scandinavia talks about equality when it comes to Sami health services. They only are prepared to extend additional services if Sami can speak Norwegian or Swedish or Finnish. So that's the deficit model, and that's not something that we may be able to draw from. But New Zealand recognized the right of Maori to have a say at every step of the healthcare system. And so what I'm suggesting as a way forward is 3 points. First, there has to be a policy response where federal and provincial government stake their claims to jurisdiction in an unambiguous way and say, you do this and I do that. and where there is a mechanism to resolve when that leaves gaps, or where misunderstanding leaves gap, that mechanism has to have teeth. And only at this point, the First Nation Health Authority in BC actually has that mechanism. But that is a model. It may not be the model, but it's a model to move forward from. The focus should be on a mix of what we have already, community-based services, self-government at that level, supplemented by Indigenous voices at all levels of the healthcare system. So it's a vertical equity supplemented with horizontal equity provisions. And in terms of accountability, I'm hoping that the next health accord will actually have an obligation for all jurisdictions to demonstrate how they are addressing health inequities in all province, territory, and federally, and be held accountable to it. And that's my presentation.